So one of the ones, biomarkers that I thought of talking about was MET exon 14 skipping mutations. And this is mesenchymal epithelial transition gene whose normal role is in embryogenesis and wound healing. In non-small cell, non-squamous, non-small cell lung cancer, the incidence of this is quite rare. It is 3 to 4%. But the reason why it is important is that we now have 5 drugs that are effective. And one of them, crizotinib, is actually labeled for ALK1 mutations, but here it has a very good potential to benefit patients. And you have seen lots of waterfall plots. So this shows that if you look at the best overall response rate, it's really fantastic. And except for 2 patients, everybody has responded. So this is an off-label option when you use crizotinib in here. But last year, there was approval of 2 drugs based on overall response rate of 68% for MET exon 14 mutation. So I will stop here as far as this biomarkers is concerned and go on to KRAS. And KRAS, of course, you know that has been a bedbug for a long time, and now we have drugs that are available for its action. But I would like to focus on one particular type of the Kirsten rat sarcoma proto-oncogene, which the mutations are between 25 and 33%. And it is like the immune checkpoint inhibitor with pedal on the brake or the accelerator. So normal function is to have, if it is off, it is in the GDP KRAS, and if it is on, it is in the GTP KRAS. So this is the mutation landscape for KRAS. 79,004 samples, 17.4% had KRAS mutations. And the one that I want to talk today is the KRAS G12C mutation, okay, which is seen in 1,632, that is 11.9%. The non-G12C KRAS mutations are prevalent in what we have known to have where EGFR mutation is there and response to TKI is there, that is females, current smokers, an age of more than 60 years. So as far as the biomarkers of KRAS G12C is concerned, this is glycine to cysteine amino acid substitution as codon 12, and it is most prevalent in 2 conditions, GI cancers and non-small cell lung cancer. Both is about 9%. Now, what is the difference between a wild type versus a mutated G12C KRAS in non-small cell lung cancer? This is data from January 2011 to 2019 from the US Clinico-Genomic Database, and the comparison was between the G12C mutation versus the wild type KRAS. And the analysis was done for treatment-related characteristics, molecular profiles, real world overall survival, and progression-free overall survival real world. Now this was found. In the G12C, the rider is that 20% actually did not receive any systemic therapy. But the remaining, the most common treatment for these patients was immune checkpoint inhibitors. And if you look at the real world overall survival and progression-free survival, when given immune checkpoint inhibitors were used in the first line, the overall survival was 12 months and progression-free survival was 5 months. And the table also shows what happened in second and third line. Now the top part is the survival for first line therapy, but the bottom row is the survival for second line therapy. And you can clearly see that as far as overall survival is concerned, there's not much difference. So when immune checkpoint inhibitors were used, the G12C mutation did not actually change the treatment or outcome of the response. So in that case, why am I talking about this mutation and why is it an important biomarker? So that is because we now have 2 other drugs that specifically can target KRAS G12C mutations. And the first one, sotorasib, got FDA approval on 28 May 2021. And the other one, adagrasib, is currently being evaluated by US FDA unless somebody in the audience knows that they have taken a decision. So what is the importance is that it's a covalent inhibitor that irreversibly and selectively binds to the switch 2 pocket within the mutant KRAS, locking it in the inactive GDP bound state. And this is the waterfall plot for the best tumor response with sotorasib monotherapy in patients with G12C mutations. So again, you can see a large part of the patients are responding. Overall response rate was 37%. Median duration of response was 10 months, which is worth evaluating and worth using in our patients. Based on Courtyard 100 study, sotorasib got the approval. Here again, I'm saying the overall response rate was 36%. The important thing for clinicians is what are the common adverse reactions which are seen in 20 or more percentage of patients. They are diarrhea, nausea, hepatotoxicity, musculoskeletal pains, fatigue, and cough. And this is the survival, progression-free survival of 6.8 months, overall survival of 10.5 months, on the basis of which this approval was given. So clearly, KRAS G12C is something that we should look for as an important biomarker that we can use. Just like in TKIs, after using for a certain while, the resistance develops. So also in this particular instance, we should expect that resistance will develop. And as can be seen on the right side, the resistance develops by another additional KRAS mutation that is seen in the patients. So this is something that we will expect in the future. So the future of KRAS medicines is we have finally approved drugs for KRAS G12C mutated non-small cell lung cancer. Mutant selective KRAS drugs targeting individual variant alleles will be like EGFR TKIs. Resistance will develop ultimately. And the pan-KRAS therapeutic targeting a broad range of KRAS would be the ultimate winners. Because if you have another KRAS mutation, maybe they will be able to circumvent that as well. Finally, for the last 2 or 3 slides, another future biomarker could be gut microbiota, because there's a strong correlation between gut microbiota and lung cancer. Common characteristics of the intestinal flora in lung cancer patients is as follows. There is decreased number of probiotics, increased number of conditional pathogenic bacterial populates, decreased abundance of genus Firmicutes, and a lower ratio of Firmicutes to bacteroides. Now, this is one hypothesis about what are the 5 pathways that correlate between gut microbiota and lung cancer. And the most important, according to me, is the lung selective trafficking, because the SFB or segmented filamentous bacteria that induce gut high 17 cells are preferentially recruited by the CLL20 positive cells which are there in the lungs. Contrary to that, this is the other view, that what actually happens is that the bacteria induced gut high 17 cells enter circulation and promote an anti-tumor immunity. So there are 2 opposite views, but whatever is it, high 17 cells and lung cancer has some link that we need to understand better. So the take-home message is that the percentage of lung cancer patients with unknown mutations is dwindling rapidly. Novel biomarkers are establishing their prognostic and predictive value with increasing data. The MET14 exon skipping mutation is firmly entrenched. That's why I only showed you 2 slides. The KRAS mutations, fortunately, are now targetable with specific agents. The KRAS G12C data is a great example of how linked agents are getting US FDA approval. And I hope and I think that gut microbiota, which have a vital role in lung cancer, will become a new biomarker that we will see in the future. So with this, I will stop here, and thank you very much for a patient hearing.
Any questions on gut microbiota for highlighting as a future biomarker?
Yes, please. So challenges is to identify the biomarker and test for it within the feces. Correct? It has to be taken. So it could be considered as a liquid biopsy because liquid biopsy could be any sample that is coming out of the body. When you are taking the feces, you have to make sure that it is processed immediately. And then what are you looking for? You are looking for the specific bacteria in the feces and not anything else. So you have to distinguish between the human DNA and the bacterial DNA. And S100 is something that we want to look at while you're doing that. And then the NGS sequencing for gut microbiota is well established. In fact, the gut microbiota is now in its 8th annual conference in United States. So the technique is well established. There is a library, publicly available library of what you have to look for, and specific bacteria that are associated with a positive outcome and a negative outcome are also well established. So if you follow those norms, then it is possible to do that. Commercially, capsule that contains feces, sterile, modified feces is also available for ingestion so that you can normalize your gut microbiota. And in India also, Dr. Shiv Sarin has used that in patients with liver disease. That he has shown that he has improved the overall survival of terminally ill liver patients by allogenic feces ingestion using a capsule.
Thank you, sir. Sir, and one more thing, there are many other factors which will influence our gut microbiota, like our diet is there, other lifestyle, stress. So how can we come to one signature?
So that I think there is enough evidence in literature with correlation between gut microbiota and colon cancer.
Yes.
And it also distinguishes the right side versus left side colon cancer. If that data was already available for lung cancer, I would not be saying it's a future biomarker. Because that data is not available, this is going to be a future biomarker. And today I am not able to give you a perfect answer for your question.
Thank you, sir.
Thank you.
Thank you, Dr. Parikh. We move on to the